अस्सलाम वालेकुम। मैं इसी फैमिली कॉन का हिस्सा हूँ, इसी का एक मेंबर हूँ और इसी के साथ मेरा सारा वक्त गुजरा है और अब भी गुजर रहा है। एंड आई एम थैंकफुल फॉर inviting me over here, and I'll present my talk for the first trimester ultrasound. So first trimester, we know, starts from the first day of the menstruation to 13 weeks. And why we do ultrasound in first trimester is they are normal. And for the patients who are coming with some sort of complaints like low abdominal pain or vaginal bleeding and these things, then along with this, locating a pregnancy, seeing its structures, knowing for the viability, dating, and of course number, we check an ADEXA for any associated mass, and of course screening for abnormalities and procedures like CVS and amniocentesis. So fertilization occurs on day 14th and implantation on 21st day. At this time, the conceptus is just 1 to 2 millimeters. It cannot be seen on the ultrasound. So for first trimester, the consensus is using transdermal ultrasound rather than TVS to visualize the structures properly. However, less than 8 weeks, TVS is superior to TAS, and 8 to 12 weeks, we can use transabdominal ultrasound too. So these are the sonographic signs of pregnancy, and we see them one by one. This thing, this first sign and 3.5 week is residual thickening, which is of course eccentric, but it is not a specific sign. Then comes this small thing. At 4.5 weeks, we see a small eccentric cystic structure in the endometrium, which may be the first sign of pregnancy, but again, it is not specific. Small cystic area with echogenic ring around it. But when we see this, we ought to do this differential for fluid in the endometrial canal secretions. Are you trying, pseudo-sac is sometimes presenting like this, then endometrial myometrial cyst like this, and there may be a small degenerative fibroid mimicking like that, and this was the case with one gestational sac and one small cystic fibroid. Then this sign appears at 5 weeks. This we call as double residual sac sign, and this is the first sign which is a more reliable, and we are hopeful for the intrauterine pregnancy, but this is not all the time present in all pregnancies. Next, the yolk sac is the first reliable sign of intrauterine pregnancy. When it is there, we are confident that we are dealing with an intrauterine pregnancy, and if we use the Doppler, we'll see the perigestal flow. However, Doppler is not advised routinely in the first trimester ultrasound. And 5.5 weeks, this yolk sac appears, and this too is eccentric in the gestational sac. This is yolk start sign. Vital index is a way of communication from yolk sac to the embryo. This is the amniotic sac, this is yolk sac, and this is the vital index. This appears on 6.5. While the amnion is appearing, In between there is one thing which we call as this thickening with the uh, yolk sac. This is the developing embryo. This is around 1.8 millimeters in size. But sometimes this situation becomes in the pregnancy. We just see this. This is double bleb sign. This is the yolk sac. This is the amniotic cavity, and this is small embryo developing. If it is pregnancy related or not, we are to follow it up, and if it grows with this, then it is normal, otherwise it can be a failed pregnancy. Yolk sac, from that small thickening, which will be only on the one side, if it is on the other side too, then it cannot be an embryo, that will be a blood clot or something like that. This stage of embryo we call as diamond ring sign, and this is around 5.1 weeks when it appears. Then we see in it, at this stage, we can see, if you can see here, in the embryo, we can see the cardiac activity. So embryo by itself is there at 5.1 week, and in embryonic heads, this small cystic area, we shouldn't confuse it with the pathology, but it's the rhombencephalon for the development of the posterior fossa structures. We see this amnion, embryo inside with heartbeat, and yolk side is out of the amniotic cavity in the chorionic cavity. When we are at this stage, we say this pregnancy is viable. First trimester, not second, third are separate requirements. Week 6, heart begins to beat, and this stage up to embryonic stage, which lasts up to 10th week, that is where we say organogenesis is going on and completed at the fetal stage, which is 10 weeks past. So in early pregnancy, normally developing pregnancies include these signs, and we say that this is a viable pregnancy for the first trimester. Now, while doing this scan, at this stage, not at the third trimester or late second trimester, we have to decide the chorionicity and amnionicity. Chorionicity equals to the number of gestational sacs. Amnionicity can be assessed by number of embryos, number of embryonic heartbeats, yolk sacs. This is diamniotic, dichorionic diamniotic, thick membrane around and thick inside. Then is thick membrane around and thin inside. This is monoamniotic, dichorionic. And this is monochorionic, monoamniotic, both the fetuses the same sac. Pregnancy dating, we used to do it by measuring the mean sac diameter, but now we don't measure it. We just, I'll give you the table how we do this. This CRL, however, is more accurate ultrasound measurement of gestational age, especially between 6 to 9 weeks. Here, a small embryo, we are measuring that, this one. Once we are sure that we are seeing the cardiac activity, we measure that small structure for the exact gestational age we call embryo. And this is the next CRL, crown rump length. The baby should not be moving, should not be in complete flexion or extension stage. It must be in neutral place, and we measure the maximum length. Now, errors occur when these things, flexion, extension, movement, or we include the yolk sac or limbs. These are the rough age. So this I was talking about this slide. When on transvaginal ultrasound, we see this gestational sac that is around 4.5 to 5 weeks, yolk sac 5 to 5.5 weeks, fetal pole. Now fetal pole, even the term is not used, I've just written it. That is small embryo appears 5.5 to 6 weeks and heartbeat at 6 weeks on transgender. All my presentation is based on transgender ultrasound. The assumption is that transgender ultrasound shows us 1 week earlier than the trans-abdominal ultrasound. So complications of the first trimester, mostly Dr. Manzoor Sahab has done. I will just run through. If the gestational sac is abnormal, like here, or abnormal yolk sac calcified, thick-walled, subchorionic hemorrhage, if it is more than half of the circumference of the gestational sac, this is poor sign of poor outcome sign. Then oligohydramnios, this is the normal side. Compare the fluid section and this embryo, and look is very tight around the embryo. Normally, this should be CRL, MSD minus CL should be more than 5 normal. If it is less than 5, that is abnormal and poor prognosis. This is normal. Then there is big sac. This one. Look at the size of the embryo and size of the amniotic cavity. This again is a poor sign for the prognosis. So these chorionic bump, the sort of hematoma, usually it resolves when it is small, but it has shown guided prognosis. Miscarriages have been considered twice than the normal if it is present. 60 to 65% overall live birth rate have been noted. Multiple chorionic bumps ended in fetal embryonic demise most of the times. However, a chorionic bump can occasionally progress to subchorionic hematoma from the second trimester onward, and there is one case report that neural tube defect, acrania, is associated with this. This is a chorionic bump. Now, if these signs are present, like we say, the fetal heart should be, embryonic heart should be there at 7 mm. That is consensus. But we can wait. If the flow around the sac is good enough, we can wait for a week or so to check for the cardiac activity, because we do not want to halt the early pregnancy and should be given a chance always. Sorry. So this is early pregnancy failure. What should we do? If CRL is more than or equal to 7 millimeters, no cardiac activity, and gestational sac, mean sac diameter is more than 25 and no visualization embryo, we follow it up. If it is not present even after 2 weeks or more, following the visualization of the gestational sac without yolk sac, or 11 days or more following the visualization of gestational sac or yolk sac, that is a failed pregnancy. So this single study of embryonic length, CRL, less than 7 and no cardiac activity, and 16 to 24 MSD, no cardiac activity. That means a failed pregnancy. So patient with these complaints, we should always remember that it is at the risk of ectopic pregnancy. That can be anywhere, like Dr. Manzoor Sahab has told. This is a tubal pregnancy. This is tubal ring. This is as echogenic as it is in the uterus for the intrauterine pregnancy. And this ring usually should be more than 2 to 3 millimeters. And that is a ruptured tubal ectopic. You see fluid around, uterus is empty, endometrium is thickened. Here is the clip of that. You can see all this fluid, and uterus is showing blood flow. Here you can see a live ectopic with cardiac activity. Interstitial, Dr. Manzoor Sahab has already told, this myometer, endometer, this distance should be at least 5 millimeters. a 5 millimeter ring of amyotrophy is not present, and we should be very careful in diagnosing this pregnancy because this ectopic is catastrophic for the life. A lot of hemorrhage occur because of the dual supply. Now this case, this is not fibroid, not nothing else. This is a bicarbonated uterus with the pregnancy in one horn and the second horn is empty with the decidual reaction. This has been discussed. Partial mole has been discussed. This is complete mole. All the cystic structures is inside. First trimester anomalies. डॉपलर बड़ी सारी मददमारी करती है खासतौर पर दो चीज़ों में, एक क्रोमोसोमल एनॉमलीज और एक कार्डियक एनॉमलीज. If there is a history of fetal cardiac anomaly in the family, if we do before 11 weeks or at 11 weeks, this is the normal waveform, triphasic waveform of ductal stenosis, SDN 3 waves, and if A wave is reversed, there are two chances, cardiac defects or chromosomal abnormality. So we can send the patient for the fetal echo. Major anomalies, I will not go into the chromosomal, but just few things. Cranial neurotube defect, more common, and encephaly. But this is basically a sequence, acrania, exencephaly, and encephaly. There is no cranium over here, and the brain is exposed to the amniotic fluid, and that dissolves, and the time comes when there is only a vascular membrane over the head of the fetus, and that typically gives this appearance of frog face or Mickey Mouse sign. Later when ये measurement छोड़ देते हैं. Now, this is hydrocapsule, and this is something else, we call it hydrancephaly. It's very drastic condition. It's because of the thrombosis of both middle cerebral arteries, and this is fluid accumulation is not because of, as in hydrocephalus, but this is because there is brain death, there is brain necrosis, and ventricles open up to fill up that space. This is the thing, we see monoventricle. We talked about there are three vesicles, prosencephalon, romencephalon, and mesencephalon. Romencephalon is developing for the posterior photostructures, and prosencephalon for frontal brain. There is lack of cleavage because of this. We see only one ventricle, and this is the indication that patient is having trisomy 13, and we will have cleft lip and this. Then there is, sorry, ये गलत लिखा हुआ, fetal cystic hygroma. This is basically thickened anti is throughout, and this is a lymphatic obstruction, and patient is with chromosomal abnormality. This is normal physiological hernia. It is resolved by 12 weeks, and the normal structure, and it should not be confused with the omphalocele, in which the gut protrudes the base of the insertion of the card, and this is covered by the membranes. The other thing, look at this. This is fetal abdomen. This is the gap in abdominal wall. This is the omphalocele. This is a membrane covering it, and umbilical cord having normal insertion. Then there is this. With Doppler, the card is inserting on the top of this membrane bag. And then gastroschisis basically all is out. Usually on right side it is present, and umbilical cord is having its normal original insertion. It is nothing to do with that. The intestines are open into the and exposed to the amniotic fluid, and there can be ascites also in this, and there can be other organs like stomach coming out. Gastroschisis, the separate umbilical cord insertion, and this I am finishing. This is multiple pathologies, multiple anomalies. This body stock anomaly is that fetal organs are attached to the placenta and getting supplied from them a very, very short sort of umbilical cord. This is liver, this is where stomach, they are all attached to the placenta. मेगासिस्टिस 7 mm से नीचे होना चाहिए फीटल ब्लैडर फर्स्ट ट्राइमेस्टर में और अगर ये 7 से ज़्यादा 30% associated with the chromosomal abnormalities in normal fetuses with more than 50 mm progress to severe obstructive uropathy and 7 to 15 mm spontaneously resolve while this can be causing the. So summary is that we should evaluate all these very systematically so that we don't miss anything. We should go for the normal structures, and for the normal pregnancy, evaluate for the presence and location, embryo and yolk sac, and also detailed anatomy scan. Thank you very much.